Hello, and thank you for listening. Today I'd like to present a unique study aimed at eliminating some of the difficulty associated with revisional surgery for recurrent hiatal hernia. We have nothing to disclose. It is important to minimize iatrogenic injury during revisional hiatal hernia surgery. This is because revisions are common. Recurrence of hiatal hernia requiring revision occurs at a rate of 10 to 15%. Patients who have clinically significant recurrence often have a large hiatal hernia defect which requires extensive mediastinal dissection. A recent article published in Surgical Endoscopy highlighted the different types of anatomical disruptions which occur and their frequency. The most common form of hiatal hernia recurrence was herniation of an intact fundoplication into the chest. So traditionally in revisional surgery, after the hiatal hernia repair, the fundoplication is taken down and redone. We hypothesized that if the fundoplication itself was intact and functioning, that redoing it was an unnecessary step, and avoiding it would not adversely affect outcomes. A retrospective review of patients with hiatal hernia recurrence who underwent redo laparoscopic anti-reflux surgery was performed. Adults aged greater than 18 years who underwent surgical repair at 2 tertiary medical centers were included. Hiatal hernia recurrence was defined as radiographic evidence of a hiatal hernia greater than 2 centimeters on videoesophagram or esophagogastroduodenoscopy. Patients who did not have an intact fundoplication identified at the time of surgery were excluded. Patients received the GERD Health-Related Quality of Life Assessment Questionnaire both preoperatively and postoperatively to compare their quality of life before and after surgery. For all patients, the distal esophagus is mobilized until at least 3 centimeters of intra-abdominal esophagus is obtained. The crura are approximated posteriorly using figure-of-8 non-absorbable sutures. Mesh reinforcement was considered based on the subjective assessment of the tensile strength of the native crural tissue. After the hiatal hernia repair, intraoperative endoscopy was performed. The Hill grade of the lower esophageal sphincter valve was determined. If the Hill grade was 1, then the fundoplication was not revised, but instead left in place, and the operation was deemed complete. This was termed a partial revision. If the Hill valve grade was greater than 1, the fundoplication was dissected, transected with a linear stapler, and then redone, and this was termed a full revision. Review of the records identified 73 patients for inclusion in the study. 33% of the patients were male, the mean age was 62, and the mean BMI was 27.5. As you can see, there was a statistically significant difference in the median BMI between the two groups, with the partial revision group having a higher overall BMI. 78% of the patients had had their original anti-reflux surgery performed at an outside institution. 19% of the patients reported reflux symptoms for greater than 10 years, and 65.5% of patients were taking proton pump inhibitors or other anti-secretory medications at their original clinical assessment. Overall median time to recurrence after the first procedure was 3.7 years. 36% of patients received partial revision, and 64% received a full revision. In the full revision group, 2 patients had a revision of a Dor fundoplication, and 4 had a revision of a Toupet fundoplication. The rest were revisions of Nissen fundoplications. Compared to the full revision group, the partial revision group had larger hernias, 4.5 centimeters versus 3 centimeters, which was statistically significant. 36 patients received a hiatal hernia repair with mesh during their redo operation. Of these patients, 13 received biosynthetic mesh and 23 received vicryl mesh. The type of mesh used and the methodology of mesh fixation did not differ significantly between the two groups. The median operative time was 3.31 hours if the original surgery was done at our institution versus 2.58 hours if the patient was referred from an outside hospital. A similar percentage of patients in both groups underwent postoperative videoesophagram and/or EGD, 69 versus 64%. Mean follow-up time for the partial revision group and the full revision group was 1.1 versus 2 years, respectively. The median postoperative GERD HRQL scores were 9 in the partial revision group and 6 in the full revision group. The 95% confidence interval for this test showed that the median HRQL scores were within 15 points of each other. Within the entire cohort, there were 2 complications, both of which were in the partial revision group. One of these was a UTI and the other was a pleural effusion which required chest tube placement. Here is a box plot graph highlighting the operative times in the full revision and partial revision groups. As you can see, there's no significant difference in operative time between the two groups. Here is another box plot comparing postoperative HRQL scores between the two groups. The partial revision group on the right had a more narrow range of scores, but the scores did not differ significantly between the two groups. Out of the 73 patients who underwent reoperation, 8 patients had a subsequent hiatal hernia recurrence, 3 in the partial revision and 5 in the full revision group. The type of mesh used had no effect on whether a recurrence occurred. Out of the 8 recurrences, 1 patient in the partial revision group and 3 patients in the full revision group underwent another revision procedure. The median time between the first and second revision was 0.88 years. The anatomic failure rate among laparoscopic repairs is as high as 60% at 10 years to as low as 7% at 6 years. Due to the overall high rates of hiatal hernia recurrence and the associated morbidity with redo surgery, there is a need to identify the critical steps necessary for a successful revision. Our hypothesis was that revising an intact fundoplication at the time of redo hiatal hernia repair was unnecessary. Review of the data demonstrated similar postoperative quality of life, recurrence rates, and complications, whether a full revision was done or solely a cruroplasty. These results are more impressive considering the partial revision group had a higher average hiatal hernia defect size. All told, the data demonstrate equal surgical outcomes without a full fundoplication revision. Our initial prediction that avoiding an unnecessary revision of a fundoplication would reduce operative times was not supported by our results. This suggests that the most difficult and time-intensive portion of the case is actually the extensive lysis of adhesions and difficult mediastinal dissection in a redo operation. The very low rate of complications overall in this cohort made comparison difficult, since no one had an iatrogenic perforation in the OR. Our study also demonstrated that GERD HRQL scores between the two groups were similar. While not proving equivalence, the narrow confidence interval suggests that patients have roughly the same quality of life after surgery. The study was limited by its retrospective nature and length of follow-up. Additionally, the two groups were managed differently based on their Hill grade. A randomized trial of full versus partial revision for patients with a Hill grade of 1 should be an avenue of future investigation. In conclusion, reinforcing the hiatus through cruroplasty alone may be a suitable option for patients with symptomatic recurrences after previous anti-reflux surgery, so long as their fundoplication is intact. Thank you very much.